morning, guys. How's everybody doing? A little warmer today, maybe? No? Okay, do we need to have a foot stomping exercise? So, when I was in Iowa, you would always see the farmers coming out and they would do their foot stomping exercise every morning, followed by some choice words about the weather. So, okay, so we're going to very quickly this morning go through accelerating learning using Plan, Do, Study, Act cycles, or PDSA cycles, and kind of touch a little bit into how PDSA cycles work, where they came from, what their origin is, and how to use them in their most simple forms. And once again, I want to thank Robert Lloyd for the use of some of his slides, as well as IHI. We were talking to someone this morning, and who I was so proud of. They said, we just stole somebody's idea. And I thought that was great, because that's exactly what we do in QI all the time, is we steal everybody's ideas, and that's why we are here after all, is to learn from each other. I've learned a lot from you all already, and like Frank said this morning, on behalf of patients around the world, my patients as well, what is going on in New Zealand is really stands to change a lot of things around the globe around opioid safety. So I applaud you in that work. So today we're going to talk a little bit about the concept of the PDSA cycle, what are change concepts, how to perform a PDSA, when to do a PDSA, prioritizing ideas, the size of a typical PDSA test, and then moving to scale. So if you want to think about, this is really how IHI thinks about drivers of improvement. A big part of what we're doing across our organizations is actually building the will to change. That's a very hard thing to do. It takes a positive attitude. It's more of a philosophy than it is anything. That the future is possible and the future is better if we have the will to do that. But we also have to bring ideas to the table. So what are the ideas that we want to bring to the table that will contribute to making the process and outcomes better? And then you have to have the capacity to apply quality improvement theories, tools, and techniques that enable the execution of those ideas. And that's essentially what QI is. And sometimes you might find yourself in a sort of tension within your organizations between these two planes. So in order to improve, you really need two types of knowledge. I would never attempt to tell an anesthetist that I know their work. I don't. I'm not an anesthetist. You wouldn't want me doing anesthesia on you. That's not my, I'm not a subject matter expert in that. The other one is the knowledge of improvement. And I'll talk about this in a minute. And this is really comes from Dr. Deming. When I first saw this, and if you're looking at this and shaking your head, I was exactly in the same camp as you. I thought, profound knowledge, my gosh, who came up with that term? But really, Dr. Deming used this to describe a type of knowledge that he said involved 4 different frames, and those were theories of systems, variation, knowledge, and psychology. And when you combine those two things, you can actually get improvement. And that's really the challenge within our organizations, is basically allowing experts to do what they do really well. They're really good at it. They trained a long time. All of you are experts in your various fields. But learning improvement knowledge, combining some of those things that Dr. Deming called profound knowledge, is really how you lead to improvement. Dr. Deming was fond of saying that a system can't improve upon itself. Basically, what he was saying is that a system can't really understand how to improve just itself. If all it knows is itself, that's all it knows. And so you have to look outside your system many times, and that's one of the real benefits of having a collaborative. So if you've not read any of Deming's work, he has some really good publications out there, but when he talks about this lens of profound knowledge, he encouraged us to think about the world through 4 different lenses anytime we encounter a problem. So one of those is we have to appreciate the system. Not only our own system, but how our own system fits in with a larger system that we might be a part of. What's amazing is, as I was sitting in the back of the room today listening to the various presentations, is that if you change one thing in a system, you affect other things. We've seen this with opioid safety in the U.S. When we started to increase the dose of opioids, we had increased rates of constipation, increased rates of nausea, vomiting, all these other sorts of things. As we started to treat nausea and vomiting, we had increased rates of constipation, back and forth. And I mean, those things are all held in tension. So there isn't a one right. It's a complex system that we're all interacting with. We also had to adjust for patients' pain scores, because if you go too far down on the opioid after acute pain, and the patient starts experiencing a lot of pain, then your post-operative complications also start to rise in that period. So again, very, very complex system that we're dealing with. The other one, you have to have a theory of knowledge. How do we learn as people? We saw examples of this today where one organization used cartoons to help people learn and to break down barriers so that people could talk about subjects. How did they teach people how to use those sort of things? And conceptually, how could people process that? It's also understanding of variation. We learned about that yesterday when we were talking about run and control charts. Those are our tools to help us understand variation and data over time. But variation is also affected by sampling, by reliability. The way we display data can actually lead to changes in variation. And probably the last one is the most important. And as Deming got a little further on in years, he really started to emphasize this point the most. You have to have a good understanding of human psychology. What motivates human beings to change? I was just having a talk with one of your colleagues, and who was commenting that so often in medicine we try to measure those things that went wrong, and we don't ask what went right. And he's exactly right. And his challenge to me was, well, do you know of anything that we measure that we do right consistently across our health systems? Anybody think of anything we measure that we do right very often? I have really struggled with that, to be honest. I think it's really, to me, that was kind of an aha moment. We do a lot of things right. Don't ever think for a moment that what you do doesn't make a difference. There's a lot of people walking around today that wouldn't be walking around without your interventions and skills. So, but that psychological value within all of our organizations, my own organization, for example, there's norms. There's definitely a cultural aspect to what goes on in my organization, which is probably very different from what would be in each one of your organizations and vice versa. We have different motivations as individuals, but also collectively as organizations. We have different behaviors because of those motivations a lot of times. So this theory of knowledge, Deming sketched out a rough PDSA cycle in 1985 on a napkin. So that's what you see off to the right here. And you'll notice that he basically drew it like a little clock, and he drew 4 steps: plan, carry it out, study it, and act. And by act, he put an asterisk. He said, adopt the change, abandon it, run through the cycle again, possibly under different environmental conditions. If you read through his books, what he always wanted to know was, and this kind of goes back to his work with statistics, he wanted to know how things performed under different environmental conditions in the plant. So he was basically trying to see would things fail, what made things fail, because he didn't want to get, just like we saw some of the data earlier from that Frank was showing with the Children's Collaborative, they had a very nice Hawthorne effect. I don't know if you saw that. We pay attention to something, it gets better, gets better, gets better. We kept paying attention to it, boom, it gets worse. We emphasize it, you know, QI project of the month, yay. And then boom, then it comes back up. So how do you build that in? And that's what Deming was really using. That was a big focus of his use of PDSA cycles. He observed this in building telephones and calculators and all sorts of things. You would think that even in manufacturing environments, you would think that when you make a change, it pretty much sticks, but it doesn't, especially when humans are involved. So he stressed the importance of the theory. The importance of a PDSA is, the most important part of a PDSA cycle is your prediction. So we all have ideas about things would make it better. I have about 1,001 ideas of things I think would make my life better. and I have a prediction of what would happen if they occurred. But sometimes when you test them out, well, maybe not so much. Operational definitions, and no true value. In other words, there's no idea that's necessarily worth more than the other one per se. And one of the things we heard yesterday was this idea of judgment heuristics. In medicine, this is a common way we're taught, and this can be somewhat of a trap. But what Deming was using judgment heuristics for was essentially judgment sampling, just like we talked about yesterday. I won't go into the double loop learning, but suffice it to say there's different ways that people come to knowledge. And so the PDSA cycle was really designed to help people approach these different ways of learning. How many people here have read the Improvement Guide? You ever seen the book, The Improvement Guide by Josie Bass? Everybody has a copy? So I put this list of change concepts in, not because I wanted you to memorize change concepts. That's not very helpful. But if you get stuck in your driver diagrams, or if you get stuck with a PDSA and you want to know kind of what's the concept behind my idea to make a change, this is a really good way. So we have ideas around eliminating waste, improving workflow, optimizing inventory, changing the work environment, enhancing the product-customer relationship, managing time, managing variation, designing systems to avoid mistakes, and focusing on the product or service. So this is the way a PDSA traditionally is depicted. So in the plan you always want to list the objective. What are your predictions? What you plan to carry out in the cycle? Who's going to do it? What are they going to do? Where are they going to do it? And when are they going to do it? And do you have a data collection plan? The do, I see a lot of folks that will make plans, but then kind of get stuck in the do. So the do gets a little harder because sometimes you have to be creative. Sometimes it's really difficult to find it. And we'll talk about that in a minute, of some tricks you can do when you're having a hard time finding the do, actually carrying out the plan. Because it's typical. We're all busy. We don't have a lot of time. And you say, I want to run this cycle for 3 days, 4 days, 5 days, over 5 patients, and maybe you get 1, maybe you get 2, but you don't get 5. After you've done that, you document your observations and record the data, and then next phase you go on to study it. You look at the data, you analyze it, you compare the results to predictions. Did it meet your predictions or not? And then you do a very quick summary of what that was. And then the act, you really have to make one of those 3 decisions. Do you keep it? Do you go back and do it again, or do you scrap the whole idea? So this is really a very simplistic way, and it's actually a PDSA cycle template that I use a lot because it's so simple that I can show it to pretty much anyone, and they can do it there's not a lot to know there. So basically, it just lists the PDSA test number, who the team is that's working on it. So, we tend to give ourselves like bird names or the names of football teams in the U.S. or things like that. We have a lot of fun with with our little PDSA cycles. We'll describe our test, usually in about 3 to 5 words. Seriously. What's our outcome? We ask, what are we going to improve with it? What's our prediction on the impact? Again, short words are better. We're not writing a novel here. I want people to just use this very, very quickly. Then the do, we collect our data and we analyze it, we study it, and then we act. What should we do with it? Did we learn anything from it? Do we want to add this sort of thing to our stream, if you will, and study how it works over time? Or do we want to add more samples and try it on a little bit bigger scale? Or do we want to revise it with another PDSA, or do we want to scrap the idea? So the times you want to do a PDSA is to build belief in the change idea. This can be really important to a team. How many of your teams always agree on what you want to change? Is that like consensus abounds? in New Zealand on all teams? Well, in the U.S., we can hardly ever agree on anything. There's an old joke that says if you have 3 healthcare workers, you have 6 opinions. So, about everything. So it is the truth, and we have a hard time to that. So you have to build belief that this change idea will actually work. The other one is to help prioritize proposed changes. So it's a way that you can prioritize which changes seem to work better. The other one is to evaluate the magnitude of improvement that a particular change might cause. To see if the proposed change will actually work in the environment in which it's being tested. Again, Deming really stressed this a lot. Okay, it worked on this ward. Will it work on another ward? Let's go test it on a patient there, or 2 patients there, or 2 simulated patients there. Decide which combinations of changes will have the desired effects on the problem you're trying to solve. You can evaluate costs, social impacts, and side effects from the proposed changes, and to minimize resistance if and when a change is implemented. So here's a few important tips about PDSA cycles. So you don't have to do a PDSA cycle when you already know something to be true. Example, you don't need to do a PDSA if wearing a raincoat or having an umbrella out in the rain keeps you from getting wet. We pretty much know that works. So avoid elucidating the obvious, as we like to say. When you test ideas out, you want to test them really rapidly and often. Again, a typical PDSA cycle for a first-line test should take about 5 to 6 minutes tops to draw up. Sometimes I'll limit my teams to only 3 minutes, and sometimes less than that. Again, I want them to not write a lot of words. I want them to test an idea out. Somebody will say, well, I think if we move this to here and that to there. So, we get into a lot of issues with built space. We have an old building. Somebody will come up with an idea and they'll say about printers, for example. What's the most efficient way to put a printer out? Okay. So we'll put the printer out and somebody will do a quick test and they'll print, and we'll look at various people, how they're walking back and forth, and they'll do a little simulation with the printer and see how much time they had. And they all have their ideas about the printer. And then we come back and we'll do little cycles on that. So to try to optimize what's the most efficient way for staff to interact with their equipment, essentially. So simple test, but you would not believe how many configurations we tested. I think we tested like 50 configurations of various staff that were going through it. Finally, I got people to agree. It took about 10 to get staff to finally come to a consensus. So again, but they all took, at the end, the PDSA cycles were taking maybe 30, 40 seconds for them to drop their PDSA, but we had a record of where we came from. We saw where we started, which was trying to save the world. And then we finally ended up with a scope plan that actually worked best for the department that everybody agreed on. Again, small is best. If you're going to do a PDSA on a patient, try it first on one patient. Maybe even don't give them a medicine or give them the therapy, but maybe simulate what would happen. And there are different ways that you can do that. If you want to succeed, in the entrepreneurial culture in the United States and many other places around the world, we have a concept of fail fast, fail often, and learn always. So most startups fail. And I was glad to see one of the teams today talk about how their first concept of the problem wasn't the correct problem. That was great. And that's actually how you learn. We learn through failing. No child ever stood up right out after he arrived, right after he was crawling first time and just walked. I mean, they all fall down, 100%. And so that's how, but they learn. And that learning is really, really important. I won't get tangential about it, but actually that's one of the issues with opioid medicines that we think is a problem, is that it actually, in some patients, when used chronically, it can impair some of that learning and feedback mechanism that your body has, which is probably why they see pressure ulcers and things like that. So in some patients like that. So again, you want to fail a lot, and about, as a general rule of thumb, you'll probably have more failures with PDSA cycles if you're doing enough of them than you will have successes. So, I asked earlier, how many times when you have a complex problem you're trying to solve does everybody agree in your organization on how to solve it? How about just on your team? Is that a challenge for anybody? So how do you solve your problem? Does somebody usually talk really loud and kind of take over the stage and say, well, we're going to do it this way, and I think this is really good, I'm a doctor? Is that how it works? Okay. Well, that's exactly how it works in my organization a lot of times. Well, I know it. I'm the head GP, and I know it all. So I'm going to help out. I solve problems. That's what I do. But what you get with that is you don't get a good collaboration. You don't get all those great ideas that kind of sit on the sidelines. There's a lot of really smart, intelligent people working within your organization. They're not who you think they are. Some of our best ideas in one of my previous healthcare experiences came from our janitor. Our janitor. The proudest day of his life, as he described it, was when he knew he saved a woman from dying from breast cancer. Want to know how he did it? He came up with an idea that he said he wore a little pin around the office, and he said, I want us to all wear pins that say, ask me about breast cancer screening, and ask me about have I had my mammogram today. So we tried various variations of this. Come to find out, his wife had died of breast cancer, and so this was a very personal issue for him, and she hadn't had her regular screening mammograms. So he was walking down the hall one day, saw one of his old friends. She said, what are you wearing a breast cancer screening lapel? He said, well, have you had your mammogram? She said, no, I didn't get my mammograms. He said, well, you better get one. He told a story about his wife. She got a mammogram. She had stage 2 breast cancer, so saved her life. So again, his idea saved lives, but if I had been the person leading that cycle, we would have never, to improve breast cancer screening, that would have never come to the forefront. I would have never thought of wearing a badge around the office would have had any impact whatsoever. And now it's standard practice. So I want to talk to you about, and if you're familiar with this approach, that's fine, but this is a very quick, down and dirty approach called normative group process. Actually, normative group process is what it's based on. But basically, this helps groups work in a non-hierarchical, informal way. It allows freedom of ideas with the general concept being that there is no bad idea. Do you have any musicians in the audience? Anybody play an instrument? You ever go to a jam session? Okay, well, all right. I used to be in a band. You wouldn't know it, but I did. I had a little bit longer hair at that time. And we used to have jam sessions. And the concept of the jam session was there was really no wrong note. They're just notes you would rather not have occur at that point in time. And what you did is we riffed off each other. In other words, it was a generative process. So somebody would start a bass line, somebody would start a drum line, and then all of a sudden we're making music together. And people are branching out and they're trying little things out. That's really a PDSA. We were doing PDSA cycles. We didn't even know it at that point in time. And that's how fun this should be. It should be a very creative process where you're trying out a lot of little ideas in very rapid space and time. Now, some of those we hung on to. Some became songs. Some became a finished product. But a lot of them didn't. A lot of them we just abandoned. We just, that's interesting, but nothing we want to stick with. So the purpose with normative group process is it allows the group to expand ideas that might not have previously been expressed. It balances the will of the group against pragmatic constraints and individual preference. And here's kind of how it works. So what you typically do is find a wall, be any old wall. If you got a white wall in the back of the clinic, that works. Or you can hang up some of that white paper, that we all love so much in QI. And on it, you put up, once you've had your aim and you know what it is that you want to improve, and maybe you're working off your driver diagram or a particular idea off your driver diagram, a concept, you're trying to come up with change ideas. I'll sometimes hang up those change concepts along beside it to kind of help folks think in terms of change concepts. And then we allow a period of time for people to just start writing down their ideas, any idea they have. And then they just start throwing them up on the wall like that. Once we get a certain amount of ideas up on the wall and the activity's kind of dying down, or maybe we time it out. You can time it out for about 5 minutes and let people write down as many ideas as they want. Now it's time to basically prioritize the ideas. And so One of those is that we come up with a little grid, and this is we call an energy grid of sorts. So the energy grid is how difficult is it going to be to implement this idea. Now, sometimes there'll be disagreements about this, but we appoint two people typically, or one person in the group, who basically sorts everything into difficulty of implementation or likelihood of idea to cause improvement. And so basically you prioritize it by that. And so you want to try to get things into one of those, either the blue grids or the green grid if at all possible. And here's how that works. So they sort them out, and then everybody gets to start voting. We give them little round dots, typically red little colored dots or yellow or green dots, doesn't really matter. And everybody gets 3 votes. You can limit the votes, it can be 5 votes, but usually a few dots per each person, so it doesn't get crazy. And everybody votes on them. And so you take the items that you want to try, so it looks like we got 8 and 9 over there, and a 7. We're going to try those. And so we prioritize them, so we'll try 9 first, we'll try 8 next, and we'll try 7 after that. Kind of makes sense? And nobody is miffed or upset because, again, it's just an idea and you move on. It just helps to prioritize your ideas as a way to do things. So it's just a nice tool that if you want to use it in your improvement work, if you're having a hard time coming up with change ideas or ideas to test, or finding consensus in which ideas to test next, it can be a really effective way to do that. It can also be effective. You can use this to help determine parts of your driver diagram as well. You can use it for all sorts of things where there's not a lot of consensus. The most important thing is that when you use the model for improvement or other improvement methodologies, you want to take theories and ideas and start off with very small scale tests in most cases. And then you have to do follow-up tests, then wider scale tests, then larger implementation of change. And again, it's really important that when you build that, then you want to study data over time to see if your change has actually led to a sustained improvement over time. This is just kind of an example of how a typical cycle would work. This was from an asthma collaborative that was working together using the chronic care model. I don't know if you're familiar with Wagner's chronic care model, but essentially Ed Wagner came up with what's called at the McCullough Institute, came up with something called the chronic care model. And this team was basically trying to find a way to improve asthma. So one of the first cycle, they gathered some sample checklist, and then they tried it on 2 patients. And then cycle 2, they agreed that worked pretty well, so then they tried it on 2 providers for a few days. In cycle 3, they did a 2-week trial and had some review meetings. Then cycle 4, they did a trial by all providers. By the time they got to cycle 5, they were basically implementing this across most of their health system. So again, part of what they were doing was testing it under various conditions, and the other thing that they were doing was trying to see if it worked once it was scaled up, and also building that will to change with the use of PDSA.